Welcome to today's Explainer. Right now, we are stepping into the shoes of a clinical detective to tackle one of the absolute most critical and, honestly, most common presentations you'll see in medicine. We're talking about community-acquired pneumonia. To really master this, we need a super clear, structured, and highly visual approach so we can cut right through the noise and get straight to the facts. We're going to break down the suspects, the evidence, and the exact protocols used to solve the case. Okay, let's dive right into this. Community-acquired pneumonia, or CAP, is an acute infection of the lung parenchyma. That's the actual spongy, functional tissue of the lungs. And the crucial point here, it's acquired outside a hospital setting. That outside the hospital detail is literally the defining feature, because it completely changes the types of microbial suspects we're hunting down compared to those nasty hospital-acquired infections. We're looking at an acute, active battle happening right inside the lung tissue. So here is our clinical workflow for today. First, meet the culprits. Second, recognizing the signs. Third, calculating CURB-65. Fourth, essential investigations. And finally, targeted treatment plans. Let's get to it. Part 1. Meet the culprits. Identifying the etiology of CAP. Our suspect pool has a really primary division, typical versus atypical pathogens. Think of the typicals as our usual suspects. Mentally highlight Streptococcus pneumoniae, for sure. It is the single most common cause of community-acquired pneumonia, period. Alongside it, we've got H. influenzae, Moraxella catarrhalis, and Staph aureus. But contrast that with the atypical bugs. These are more like our rule breakers. They just behave differently. Mycoplasma is a classic suspect when your patient is a young adult. Legionella, that should immediately jump to your mind if there's a history of recent travel or a known outbreak. And then, of course, we have chlamydia. Knowing this division is absolutely step 1 in our detective work. But hey, bacteria aren't the only ones breaching the lungs. Viral pathogens are massively important culprits too. Influenza, SARS-CoV-2, and RSV are frequently the primary invaders. It is so vital to keep your differential diagnosis broad here because, as we'll see in a bit, identifying a viral versus a bacterial culprit completely alters our entire treatment strategy. Section 2. Recognizing the signs. Looking at clinical features and the physical exam. When a patient with CAP walks through the door, the presentation is acute. It demands urgent attention. We're looking for a fever threshold of 38 degrees Celsius or higher. The patient is typically going to present with a productive cough, often with purulent sputum, and sometimes even hemoptysis, coughing up blood. They're dealing with dyspnea, so shortness of breath, and pleuritic chest pain, that sharp pain that just catches them when they try to take a deep breath. Systemically, they feel awful. Profound malaise, myalgia. This is a system under severe acute stress. Now, when you put your stethoscope to their chest and begin your physical exam, you're listening for some very specific acoustic clues. You'll hear crackles or crepitations. You might hear bronchial breathing, where the breath sounds are surprisingly harsh and loud over the lung periphery. You'll definitely note increased vocal resonance, and when you percuss or tap the chest wall, you'll hear a distinct dullness. These specific auditory and percussive clues are the classic, undeniable hallmarks of lung consolidation and pleural effusion. The lung, which is normally filled with air, is now basically bogged down with fluid and inflammatory debris. Section 3. Calculating CURB-65. Assessing the threat level. Okay, I want you to think about this for a second. You've got a very sick patient right in front of you. How do you actually decide who is safe to go home with a prescription, who needs to be admitted to the ward, and who absolutely needs to be rushed straight to the intensive care unit? Enter the CURB-65 score. This is an incredibly elegant and high-yield triage tool. Let's see how this builds, anchoring each letter to a vital threshold. C stands for confusion. Is the patient newly disoriented? U is for urea, specifically a level greater than 7, which tells us if the kidneys are taking a hit. R is for respiratory rate. Is it dangerously fast, at 30 breaths per minute or more? B is for blood pressure. Are they hypotensive? We're looking for a systolic below 90 or a diastolic at or below 60. And finally, 65. Is the patient 65 years old or older? It's simple. Each of these indicators gets exactly 1 point. So once you tally those points, the clinical pathway becomes crystal clear. A score of 0 or 1 means the threat level is low enough for outpatient care. They're safe to go home. A score of exactly 2 means they require inpatient admission. Get them on the ward. But a score of 3 or higher, that patient is critically ill and needs to go to the ICU right away. This simple scoring system brilliantly standardizes triage. It literally saves lives. Moving on to Section 4, Essential Investigations. Let's run the forensics. So the crucial starting point here is absolutely mandatory, a chest x-ray. You have to look for that infiltrate or consolidation. It's the absolute key for a diagnosis. Below that, we run our basic labs. A full blood count, CRP to measure the inflammation, UNEs to check those kidney functions we just talked about, and liver function tests. But look closely at procalcitonin, or PCT. This is an incredible biomarker. If the PCT is low, the evidence strongly suggests a viral cause. But if it's high, it points the finger directly at a bacterial culprit. It is a fantastic tool to help you differentiate between the two. Now, as the severity of the pneumonia increases, well, so does the precision of our forensics. For severe cases, we really escalate our investigations to target exact microbial identities. We're ordering blood cultures to see if the infection has gone systemic. We request sputum cultures and gram stains. We check urinary antigens, which, by the way, is incredibly specific for catching pneumococcus and Legionella. And we utilize PCR testing to hunt down the DNA of mycoplasma, chlamydia, or our viral suspects. Basically, we leave no stone unturned for our sickest patients. Section 5. Targeted Treatment Plans. Executing the takedown using the latest IDSA and ATS 2025 guidelines. Now, what's really interesting here is how beautifully this escalation of antibiotics maps directly back to the CURB-65 score we calculated earlier. For outpatients, so those with a score of 0 to 1, the first-line regimen is amoxicillin 1 gram 3 times a day or doxycycline to cover the atypicals. For inpatients sitting at a score of 2, we escalate to IV antibiotics, ceftriaxone plus azithromycin. And for our ICU patients scoring a 3 or more, we hit hard. It's either ceftriaxone plus azithromycin, or we bring out the heavy artillery, levofloxacin plus vancomycin, specifically to ensure we've got solid cover for MRSA. To finish our treatment plan, I have 2 final clinical pearls you absolutely must commit to memory. First up, the standard duration for these antibiotic regimens is 5 days. However, you've got to use your clinical judgment and extend that timeline if the patient remains clinically unstable. Second, if your forensics reveal a viral co-infection, specifically influenza right alongside the cap, you must add oseltamivir to the regimen. We've built a robust, structured understanding of community-acquired pneumonia today. From identifying typical and atypical culprits to mastering the CURB-65 triage and executing targeted guidelines, you now have the detective's toolkit to tackle this acute disease. But I want to leave you with a provocative thought as we wrap up this explainer. With microbial resistance steadily on the rise globally, shifting the very nature of these pathogens, how long will our current first-line therapies actually keep community-acquired pneumonia at bay? It's a massive question, and it's one that every clinical detective needs to keep in the back of their mind as the landscape of infectious disease just continues to evolve.